And now, let's discuss on how to make the diagnosis of asthma. The diagnostic criteria for asthma in adults include history of variable respiratory symptoms and confirmed variable expiratory airflow limitation. So what are the patterns of respiratory symptoms of asthma or in asthma that increases the probability that this is really asthma? First, we have more than one symptom, either wheeze, shortness of breath, cough, or chest tightness, especially among adults. Symptoms are often worse at night or early in the morning. That's why if you are highly considering that this patient has asthma, we have to ask if the symptoms of which was mentioned earlier are worse at night and early morning. Usually, patients with asthma would say, mas grabe ako ang hangos sa gabi, mas mapukaw ko sa kadlawon kay gaubog ko, nga dili ka kawala, nga gahangoson ko. That's what they would usually say. If it occurs at any time of the day, you have to have a differential diagnosis, or you have to consider another diagnosis. But the asthma is still not totally ruled out. Symptoms now would vary over time and in intensity. So there are times wherein the patient would say, I had cough the other week, and then after a few days it went away, and then I was okay in the previous week, but now for the past 3 days I have been having on and off cough, and then last night I had bouts of coughing that made me so breathless after each coughing or after each bouts of coughing. So it can actually really vary, because sometimes also these patients with asthma would have, since they would have worse symptoms at night, when they come to our clinic, when they come to the clinic in the morning, they are usually okay. They would say, arang-arang karon na wala ko'y ubo. But at night, it's really very bad. Now, symptoms can be triggered by any of the following: viral infections or colds, exercise, allergen exposure, changes in weather like sobra ka init, sobra ka bugnaw, laughter, irritants such as car exhaust fumes, smoke, or strong smells. Even if it's the smell of a perfume, it can still trigger an asthma attack. So in history, we have to ask for history of childhood asthma. If the patient has been admitted for asthma, or does the patient have history of using a nebulizer or an inhaler for coughing or for whatever reason. Then we also have to ask, this is very important, is allergic rhinitis or eczema. Most patients with asthma have allergic rhinitis. Eczema, if they wouldn't say eczema, ask them if they have had history of skin asthma, because I've heard a lot of patients that would say, I have history of skin asthma. So that's actually eczema. Always ask for family history of atopy. So atopy is actually a spectrum of diseases wherein your asthma, allergic rhinitis, eczema, urticaria are included. So in physical examination, they are often normal, because most of the time our patients would come to our clinic in the daytime, and most of the time these patients will not present, their symptoms will not be as prominent as when it's nighttime. So when they come to you, they are often normal. However, we may notice that the patient has wheezing. This is the most frequent abnormality on physical examination. However, it may be absent or only heard on forced expiration. So what is forced expiration? When you ask the patient to cough. If the patient would have what I would call as a wheezy cough, meaning, or when you hear wheezing and auscultation when you ask your patient to cough, then that will warrant or that will be considered as a wheeze. The problem if the wheezing is absent is when breath sounds are altogether absent. Now, if their breath sound now is absent, meaning there is a silent chest, that's actually a signal of a severe bronchospasm. Walay hangin, mapdunggan kay walay hangin gasulod. So that's actually more dangerous. So if you note that on physical examination, it's important to bring the patient to the ER for admission and prepare for intubation. Crackles or crepitations and inspiratory wheezing are not features of asthma. However, you can still hear these in the patient with asthma, considering if the patient also has a concurrent problem. You usually hear these in patients with cardiac problems. Examination of the nose may reveal signs of allergic rhinitis. There could be inflammation, redness, or swelling in the nasal mucosa, or you can actually see a nasal polyposis. This is the diagnostic flowchart of GINO 2024. So we are presented with, if you are presented with a patient with chronic or recurrent respiratory symptoms, we have to consider if these symptoms are typical of asthma. If they are, we have to dig deeper, get a detailed history and examination. Now, if the findings of the history and physical examination would support the diagnosis of asthma, and the patient is not taking any inhaled corticosteroid treatment or ICS treatment, we have also to take into consideration if the patient have severely uncontrolled respiratory symptoms, which will be discussed later. If the patient has no severely uncontrolled respiratory symptoms or is able to perform further studies, you have to refer or to request for a spirometry or a peak expiratory flow meter, whichever is available in the area. In Cagayan de Oro City, we have one hospital that can do, two hospitals that can do spirometry. One is in Capital University Medical Center and the other one is in Northern Mindanao Medical Center. I'm not sure with the other big centers, but these are the ones that I know of that would regularly perform the spirometry or the pulmonary function tests. Now, peak expiratory flow meter or PEF can actually be done in the offices or the clinics with the doctors or the pulmonologists. Now, if these are available, then you have to request this to be done on our patient. So we do a spirometry or pulmonary function tests with pre or post bronchodilator study, meaning the patient will have a spirometry testing before a bronchodilator is given and after a bronchodilator is given. So this is what we call, because this is very important because it will tell us if the patient has reversibility. The airway limitation has reversibility, which is actually a feature of asthma. So to be able to diagnose that the patient has an obstructive lung defect or lung disease, based on your pulmonary function tests, like the spirometry, we usually look at the FEV1-FVC ratio. If the FEV1-FVC ratio is less than 70% or is less than 0.7, then that patient has an obstructive lung disease or defect like asthma, and to be able to determine if the obstruction is severe or not, we take into consideration, or we look at the FEV1. So remember, FEV1 FVC ratio is the one that is used to confirm the diagnosis of asthma or an obstructive lung defect or disease. And FEV1 is used to determine the severity of the obstruction. Now, but you have to make use of the post-bronchodilator FEV1 FVC ratio and the FEV1, not the pre-bronchodilator values. Okay? Now, so if the spirometry will establish the diagnosis of asthma, then we have to address or treat asthma using an ICS containing treatment or medications, which will be discussed later. If, however, on spirometry, there is no variable expiratory airflow on that spirometry, we can actually consider repeating the spirometry when the patient becomes symptomatic. Okay? This is what was mentioned earlier, the spirometry with pre and post bronchodilator study. So this is usually done by a respiratory therapist in the PFT room, and it's usually done using either a portable spirometry machine or with a body plethysmograph, or what we uh, commonly say, or in the layman's term, a body box. This is what a PAF or a peak flow meter looks like. So this can be done in the clinics of doctors or pulmonologists who have these available in their clinics, and those who are have been properly trained on how to perform these tests. Now let's proceed the assessment of asthma control. How do we go about in assessing if the patient has controlled asthma or not? This is the asthma management cycle for personalized asthma care. So it's really in circle because you have to follow the cycle of the asthma management for each and every patient that you would have with each and every time that they would come to your clinic for consult or follow-up. So this management cycle include review, assess, adjust. So how do we assess asthma control in adults? So we have to consider the following: asthma control symptom, risk factor for poor asthma outcomes, risk factors for exacerbation, risk factors for developing persistent airflow limitation, and risk factors for medication side effects. We first go to the asthma symptom control. Gina makes use of this checklist to determine symptom control among asthmatics. So within the past 4 weeks, the patient has had any of the following. So did the patient have daytime symptoms for more than twice a week? Are there any night awakening due to asthma? Is reliever needed for symptoms more than twice a week? Or is there an activity limitation due to asthma? If the patient have none of these at all, then it's a well-controlled asthma. If the patient presents any of these, 1 to 2 of these, within the past 4 weeks, the patient is considered as partly controlled. And if the patient have 3 or 4 of these, or have answered yes to 3 or 4 of this checklist, then the patient has uncontrolled asthma. What are the risk factors for poor asthma outcomes? It is important to assess risk factors at diagnosis and periodically particularly for patients experiencing exacerbations. We have to measure FEV1 ideally at the start of treatment, after 3 to 6 months of control or treatment, and periodically for ongoing risk assessment. This is ideally. Now let's go to risk for exacerbations. The following are the risk factors for exacerbations. Patients who have had high SABA use, meaning they have been using more than 3 canisters of the salbutamol Ventolin or has been having more than 200 inhalations in the past year. So in a year, if they are overusing or they are using the short-acting beta agonist in the form of salbutamol for more than 200 times, then they are already actually have the increased risk for exacerbations, meaning their asthma is really not in control. Also, we have next is the inadequate inhaled corticosteroids. Before, all patients with asthma are primarily treated with short-acting beta agonists alone. However, in the recent studies, in more recent times, it is of utmost importance to include inhaled corticosteroids in the treatment for the control of asthma. Because, as mentioned earlier in the first few slides of our lecture, inflammatory cells are one of the main players of causing asthma in our patients. They are the ones who causes the inflammations with the mediators that they secrete. So to suppress this inflammation, we have to have inhaled corticosteroids as part of our management for patients with asthma. Other medical conditions that can actually increase the risk for exacerbation, we have obesity, chronic rhinosinusitis, GERD, confirmed food allergy, and even pregnancy. Exposures to either smoking, e-cigarettes, or allergen will also increase the risk factor for exacerbation. So we really have to ask also if the patient has been exposed to, what do you call this one, to dander. Maybe the patient has a pet. Is the patient exposed to smoke? Kanang maghaling bitaw. Smoke. Even exposure to construction pain, or yeah, you have to also ask them what are the possible triggers for the exacerbations. Another risk factor is the psychosocial, because major psychological and socioeconomic problem can actually be a trigger for exacerbation. Aside from that, this factor is brought about by the patient not being able to purchase his or her inhaler. And finally, you have lung function. Patients with already low FEV1 and high bronchodilator responsiveness, they are actually have increased risk for exacerbation. Type 2 inflammatory markers in the presence of higher blood eosinophils as well as elevated FeNO, they are also indicative of a patient with increased risk for exacerbations. So yes, it is important to include CBC as your initial workup in patients with asthma, though it does not necessarily mean that all patients with asthma should have CBC taken with each and every clinic visit. So you can actually just do it once a year. So if patients have eosinophilia on the CBC, then it will help you realize that the patient has an increased risk for exacerbation. Hence, they are more likely to maintain the inhaled corticosteroid LABA combination. We also have to ask for the exacerbation history. If the patient has ever been intubated or has been admitted to the ICU for asthma, or if the patient have had more than one severe exacerbation in the last 12 months that caused the patient to be admitted, are also factors for exacerbations. Now let's go to the risk factors for developing persistent airflow limitation. First, we have history. Is the patient preterm? Was the patient of low birth weight? Was the patient have great infant weight gain? So these patients actually would have are more likely to develop persistent airflow limitation. Patients who lack ICS treatment in patients with history of severe exacerbation also would precipitate or predispose the patient of developing persistent airflow limitation. It's also very important to elucidate data on exposure to tobacco smoke. Patient may be a previous smoker, a current smoker, or a passive smoker. So it's very important to ask these. If the patient have history of being exposed to noxious chemicals like pesticides, if the patient is working in a factory like Del Monte, is the patient working in a construction site often, like patients who are engineers, patients who are construction workers. So you have to ask these information. You also have to consider that these patients with low initial FEV1 on spirometry as well as positive or presence of sputum or blood eosinophilia, they're also they're most likely to present with or more likely to develop rather persistent airflow limitation. What are the risk factors for medication side effects? So those patients with history of frequent oral corticosteroid use or OCS and those who have long-term high-dose and or potent ICS are more likely to present with medication side effects secondary to the steroid use. So anything that would be brought about by this prolonged use of your steroid, these patients are more likely to present them. Also have to consider if the patient has high dose or poor ICS as well as poor inhaler technique. So if the patient have poor inhaler technique, then the side effect would be the asthma of the patient is not controlled properly. So how do we assess asthma or severity? It could be considered as mild, moderate, or severe. Mild asthma, these are patients who have well-controlled asthma and who are making use of low-intensity treatment, meaning they are either just using an as-needed reliever medication alone or using a low-dose ICS plus as-needed SAPA. For moderate asthma, these patients are more likely to be well controlled using the step 3 or step 4 treatment in the GINA, which will be discussed later. Severe asthma are those patients who requires step 4 or 5 treatment. So these would involve high-dose LABA ICS.